we all know, there's been an ongoing mpox outbreak in Uganda, but specifically in DRC that has moved down to, other neighboring countries around DRC. A lot of it is also has been in the West Africa, the South Africa. And so with that challenge, global challenge ongoing, especially on the continent. So I and a group of other colleagues from different countries, Ghana, Nigeria, Cameroon, and Ethiopia, sat down and decided to leverage on mathematical modeling techniques to sort of like see how best we can avert the mpox outbreak, and specifically just trying to see the role that the different transmission pathways play, also the age dynamics, given that the recent outbreak before the current one, we noticed that it was more in adults, and it was mainly in adults because they were the pathway then was a sexually transmitted, that's specifically the CLED1B. But also we noticed that with the current one, even the children are getting it, but then also there are different other transmission pathways that are coming to really play a very big part in terms of transmission. So that was the whole mind behind us coming up with such a project, but also trying to see how the different interventions would really help in averting the mpox cases. So just a little bit of the agenda. I'm going to run through this because I have another meeting which is actually running now, but we'll have sort of an introduction objectives. We'll look into the model, the output, policy recommendation, and the next steps that the team is currently working on. Maybe just remind ourselves, according to Sir Ronald Drost, says that the control of epidemics lies in our understanding of the chain of transmission. That is really important. But also, according to Daniel Bernoni, says it is far better to prevent than to treat, for even the gentlest interventions can often have far-reaching effects. So maybe just a little bit of what mpox is, especially for those of us who could be hearing it maybe for the first time, who have not really taken time to even read about it. So mpox is a viral zoonotic disease. It being zoonotic, it means that it's transmitted, it can be transmitted from animals to human beings. It's caused by an mpox virus. And there are two strains. There is the CLED1B strain, and the reason as to why it's called, the other name for the CLED1B is the Central African Region CLED. The reason it's called so because it originated from Central Africa, and some of the characteristics of this CLED is that it's more severe, and it manifests with severe clinical signs and symptoms. And then there's the CLED2B, also known as the West African CLED, and this is associated with the milder forms of the disease. Looking into the natural history of the disease, right when someone gets exposed, they have about 7 to 17 days of incubation, and then thereafter they get into the prodrome phase, which is usually characterized by a fever, among other signs and symptoms, headache, fatigue. But thereafter, right after the 4 days for the prodrome disease, prodrome phase, the patient goes into the rash phase, and it's usually in the rash phase that they can easily transmit this disease from one person to another. And after specific interventions based on how the patient presents, they can either recover from the disease or even end up getting severe complications from the disease, with death being among these. So how is this disease transmitted? Like we said, it's a zoonotic disease, meaning it can be transmitted from an infected animal to human beings through contact. But also the disease can be transmitted from one human being to another, either through other non-sexual contact pathways, maybe by touching the infected person or direct exposure to the mucous membranes, but also through inhalation of the aerosols and the sexual pathway, like we already said. So how can we prevent ourselves from contracting such a disease? So we should avoid getting into contact with animals that especially carry the virus, but also from amongst ourselves by making sure that we clean up our hands, we get vaccinated, and then we also get to know the information regarding the signs and symptoms, but also how to protect ourselves from contracting the disease. In terms of management for this disease, it's important to note that there is no specific treatment for mpox currently, although treatment is per case presentation. So if someone has a fever, you give them an antipyretic. If they have a rash, you try and see how best you can. I'm sorry about that. How best you can protect, how best you can treat them depending on how they are presenting. So what is the current situation like in Africa? So in Africa, we have the Clade 1B, which began in September 2023, and it began in DRC. And the number of cases have been increasing, like Aaron said in my introduction, and expanding to the nearby countries, the Central African, the Eastern Africa, and the West Africa, but also there's also been the South African, where it has specifically been more common in people living with HIV. So the strain spread really rapidly among adults through close contact, specifically the sexual contact. But because of this, realized that the virus further spread even to other, groups of people, the children, especially school-going children. And we can see that congestion really played a very important role, especially in the school ongoing children. So with those numbers, as the numbers kept on increasing, there was a declaration from WHO for public health emergency of the disease on the continent. As of 6th October 2024, we had at least 16 African countries affected and about 36,000 suspected cases, with about 7,000 of those being confirmed. Yeah, and then again, as of 6th October 2024, there were about 998 suspected death cases, with 25 of these confirmed. So the number of strains, like we said, we have currently, with the current, pandemic, or the current pandemic, we have the Clade 1B, the Clade 1 Mpox outbreak in Congo. There's the 1B in DRC, and then the 2 in South Africa, like I said, which was specifically affecting people living with HIV as per this date, under what the statistics are currently. And then, as per the current situation in Africa, then when this presentation was made, the management was that there was a public health response where WHO coordinated with different local governments from the different countries to see how best they can put an end to the epidemic, but then also risk communication via different public sensitization platforms to make sure that at least the public is aware of what exactly is going on, as well as surveillance and laboratory support to make sure that they're doing as much contact tracing as possible, but also having all the equipment that they need to be able to identify those with the disease. In terms of a DRC, and the reason as to why we decided to zero down to DRC, this is because the data on which the model was fed was a DRC data. So we decided to give the current situation in DRC, and as per then, the first case was identified in September 2023, like Aaron said, that was in the province of Kivu. And as of 6th October, DRC had the most reported number of cases, with approximately plus 200 cases reported per week, which is quite high. No wonder it was declared a public health emergency. Yeah, and then we noticed that more than 50% of the cases were found in children less than 15 years old, which are school-going children. So you can imagine that with the most recent strain of the Mpox, there was a shift in the transmission pathways, because children who are less than 15 years old are usually not sexually active children. So we do not expect them to have gotten the disease via the sexual pathway, but via the contact pathway, for example, and probably because of the congestion that is usually associated with the African schools. So the objectives of this project was to estimate the Mpox transmission rates, both within and between children and adult populations in the DRC Congo, but also to estimate the impact of contact tracing and isolation measures on the number of Mpox cases that can be averted over time in DRC. Please note that when we talk about children here, we are talking about children who haven't yet attained the age of them being sexually active, but also Africa being a bit different from the other countries. We considered 15 years and below for children, and those who are above 16 were considered as adult, as they're into their reproductive stage and as such can indulge themselves in sexual activities. So the transmission pathways that were considered in a model, whereas this, we said that if a child is infected, they can end up infecting a susceptible child. So the susceptible child can get the disease from either an infected child or an infected adult. And this pathway is mainly through the contact or the aerosol, so basically the non-sexual pathways. And then a susceptible adult can end up getting the disease from an infected adult, which can be through the sexual or the non-sexual pathways, but can also get the disease from an infected child through the non-sexual pathways like aerosols, contact, and others. So this is what the model looked like. We have a susceptible child, which susceptible child can either get the disease from a fellow child or from an infected adult. This susceptible child can get it from an infected adult, and then this can move to being infected because they got into contact with someone that had the disease. So when they get infected, some of these can be identified, that is detected. The infected child can end up being detected through identification. Maybe they have gone to the hospital and they have been able to they're being told that, okay, you have mpox and things like that. And there, like as per the case presentation, the child can end up recovering from the disease because of some intervention that is being provided at the facility, depending on how the child is being presented, or that the same child who is detected can end up succumbing from the disease regardless of the management that has been provided. However, we are also saying that there are some children who will be infected but may not be detected, that is, remain in the community. And from this also we'll have a proportion of those that will recover and those that will die. The difference is that the rate at which those who are infected and remain in the population vis-a-vis those who are infected and are detected recover or die is quite different. And this is because those who have been detected have some bit of intervention that is provided compared to those who remain in the community. And that's why we have different rates. And then because this was an heterogeneous model that tried to look at children and adults, we have also susceptible adult who can get the disease from an infected child, right? Any of this infected child. So the pathway is child to adult transmission. Or we also have a susceptible adult who ends up getting the disease from an infected adult. Again, from these infected adults, we have those who will be detected and those who remain in the community undetected. And from the two groups, we have people who will die and recover from the disease. So the rate at which they recover and die will be different because those who are detected have some bit of intervention provided compared to those who remain in the community undetected. So we have been speaking about what the different symbols mean, with S having susceptible. So all S mean adult and all Cs mean child, but the S stands for susceptible, I is infected, child, ID is the identified child or detected child, recovered or dead child, and the same applies to the adult population. For the interest of time, allow me to skip the ordinary differential equations that were considered. And then when we move down to the model assumptions, we assumed that children can only get the infection via other pathways other than the sexual pathway. And then the adults can get the infection via any of the transmission pathways, whether sexual or non-sexual. And we also considered it being as a closed system, so we ignored any births or deaths, or any migration. So we ignored anything that comes in or leaves, as long as it's not leaving because of mpox. So other causes of death other than mpox were not considered. And then also we assumed that reinfection is not considered. So once the person gets mpox, they recover fully and sort of like get immunity. to the disease. And then we also assume that the population is considered to be well mixed, so there is that homogeneous mixing in the population, that anyone susceptible has a similar chance of getting into contact with an uninfected person. So there is no that this particular group of people is highly susceptible compared to the other. No, the probability was, the chance was equal for everyone that was considered, both adults and children. We also assume that the transmission rate for children who acquire it from their fellow children is quite higher compared to the adult who get it from their fellow adults. And this is because we're looking at children in congested places. This is because we're assuming that when you're in a congested place, it means you quickly acquire the disease compared to when you're not in a congested place, given that you can get it through contact or even through aerosols. So this is what the simulated SIRD model looked like. And before fitting the model onto the data, we specifically got to look at the epi curve for the DRC data that was received from September 2023 to September 2024. And we can appreciate that there was an increase over time in the number of cases. We leveraged on the least squared error method to estimate the different parameters based on the DRC Congo data, and we noticed that there was a 100% transmission rate for child to child. So the chances of a susceptible child getting into contact with an infected child was and resulting into an infection was 100%, but also for an adult to child. Based on the model, it gave us 100% rate. And we think this could be because maybe children have a very low immune, in that when they get into contact with someone that has the disease, they quickly contract the disease and get the disease, unlike someone whose immune is quite stronger. If the inoculation for the virus is a bit low, maybe the virus could help fight off the disease. But also if they have fallen sick from other related similar diseases like chicken pox or some other disease, maybe there is that memory in their immunity that can sort of protect them. We can see that the transmission adult to adult and child to adult was quite lower compared to the adult to child and child to child. And then for the recovery rates, we can see that the recovery rate, again, I hope gamma is recovery, sorry, just trying to check. Yes, we also noticed that the recovery rate for children was quite higher for adults. Yeah, so regardless, it was quite higher for adults. So regardless of maybe some adults having immunity and not easily contracting the disease, we also noticed that children had higher recovery rates compared to adults. And I think some of this could be because maybe the amount of care that is being given to the child, but also the child not worrying that they can easily die from the disease compared to an adult who may be so much, worry, but also because the child may, take some time off and be home and things like that, and, have that faster recovery compared to adults. But also considering that we did not have like a cutoff for the adults, and maybe the elderly adults whose systems are already low, and so if they now get this other disease in addition to maybe some other chronic illnesses that they have, it can sort of like lessen their recovery process. But we also noticed that the recovery for identified child again was higher compared to the recovery for the identified adult. And in terms of what this is, sorry. Okay, detection rate. We also noticed based on that data that the detection rates for adults was higher than that for children. We wonder what really would explain this. Maybe mothers were worried of having their children contract more diseases from hospital, things like that, or they thought it was something else, the normal, bumps that children get on their skin, and maybe took some bit of reluctance compared to adults, or also because maybe adults move around and can easily be identified compared to children. We wonder why the estimates turned out like that. So based on the fitting of the model, this is what the fitting looks like. We can see that it sort of like it tried to fit the data a little bit fairly well. Yeah, so we can see that the red line, which is the predicted, sort of like takes on most of the actual number of cases, showing that the model didn't do so bad. And then when we go down to trying to evaluate the different interventions on the number of cases that are averted, we can see that with contact tracing at different rates, that as maybe before we can look into the plot, we had to ask ourselves what parameter does contact tracing affect? And we say that contact tracing will affect the detection rate. And how will it affect it? It will affect it by increasing the detection rate. So the more we increase the contact tracing, that is the more we are able to, detect those who have been exposed or those who are infected. And that means in the long run, as we take them out of the community, we are lessening the rate at which those who are susceptible get into contact with them. And we can see that as a contact tracing increased, there was an increase in the number of cases averted. Like you can see at a contact trace of 70%, who are almost getting to zero number of detected cases compared to a 10% contact tracing. And when we go down to trying to look at the statistical, expression of these outputs, we could see that when we compare the no intervention at all versus the 10%, we are able to avert approximately 10 cases over time. But then when we increase the contact tracing to 40%, we're able to avert 80 cases and also 70%, 101. Of course, that is in comparison to the no intervention at all. And we can see that the 80 cases and the 101 cases averted gave a statistically significant decrease in the number of cases averted. The other intervention that we looked at was the isolation, and we also asked ourselves what parameter does isolation affect, and we agreed that it does affect the transmission rate, and this is because you get to isolate someone who is infected, but also because someone who is susceptible has to get into contact with an infected person to get the disease. So it means that the more you're able to take away as many infected people as possible, it means you're trying to reduce the transmission rate. So we saw that with isolation being increased, we shall be able to reduce on the transmission between children and children, adults and children, adults and adults, and children and adults. So we realize that as isolation increases, we are able to have a reduction in the number of cases. Please note that isolation, even 1% a 1% isolation gave sort of like similar results to a 10% contact tracing. So meaning isolation is a very important component when it comes to averting cases, especially pandemics. Yes, so we noticed that when we compared the 1% isolation versus the no intervention at all, we were able to avert approximately 18 cases, though this wasn't a statistically significant aversion. However, when we applied a 4% isolation versus the no intervention at all, we're able to avert 64 cases, and this gave us a statistically significant decrease in number of cases averted, and the same applied to the 8%, which averted approximately 95 cases. Now, in terms of combination, Uganda is a resource-limited country, and the same applies to DRC Congo, the same applies to Burundi, which was highly affected, Rwanda, Ghana, mention it. So you realize that it may not be possible for these, limited resource setting countries to just provide one intervention fully, let's say provide 100% contact tracing. And this is because the resources may not be available. And so we said, what happens if we combine little by little of what we have? Are we able to achieve much more that we should have rather achieved when we just apply just a 100% intervention? So we noticed that at smaller rates for each of these interventions, which is the both purple, who are able to avert almost something that is similar to 100%, let's say contact tracing or isolation. So the thing is that when we combine different interventions, however small they may be, the 40% and the 4% of isolation, we're able to get like an additive effect versus when we just use one intervention, which may not be applicable to a country like Uganda, which is resource limited. So we noticed that just contact tracing alone averted 80, contact tracing at 40%, then isolation at 4% averted 64. However, when we combined the 0.4 and the 0.04 for isolation, we're able to get 110 cases averted, which showed an additive effect with a combination of interventions. In terms of policy recommendations, we noticed that there's cost efficiency through combined interventions. Like we have said, combination of lower rates of interventions can rather give us can give us a larger reduction in the management of such diseases. But also we noticed that resource optimization and sustainability for low and middle income countries. So there's this reduces the need for intensive scaling of just a single intervention. So we're able to bring into play all the little that we have all together, maximize it and utilize it in the fight of the epidemic or pandemic. But also there is also enhanced impact through multi-intervention strategy. So what was the take home based on this project? The take home was that the spread of mpox can best be reduced with multiple interventions and not just a single intervention. So don't just sit and say, oh, we do not have this, or we do not have enough of this. Just put together all that you have, and when you put it all together, you'll be able to get a maximized effect. But also we learned that early intervention can help prevent the spread of the disease, of course, following the 717 Alliance strategy. Education and sensitization on the modes of transmission is really important, and this is because once the public is aware, it's able to take into all the necessary steps to sort of like curtail the spread of the disease. But also sustainability in disease control lies in balanced resources, as well as smart and scalable interventions put us ahead of the curve in the management of pandemics and epidemics. So currently the team is writing a manuscript. We were promised more data to apply a model to other African countries. The data hasn't yet come through, so we have decided to proceed with a manuscript for publication. And of course, acknowledgement to go to the German West African Center that provided us with this training, which then resulted into us sitting down and coming up with such a model, but also IDRC, where I happened to work. The Makerere Lung Institute, and now also the TGN that has given us the platform to share our work with them. Thank you all. Over to you, Ashna.
Thank you. That was amazing. Before I have a question, but before I ask, does anybody else have any questions for Shakira? Maybe people are digesting, but
just to congratulate her. Yeah, just to congratulate her. Very, very wonderful one. Thank you.
Thank you.
Yeah, my question is whether you have also considered using structural equations modeling, SEM, to map out the pathways.
Well, we haven't yet considered that. We also had some more feedback from the recent presentation that we made at Ministry of Health here, where we were told to do some bit of agent-based modeling. But yeah, we can try the structural equation modeling and see how it turns out. Thank you so much.
Amazing. I had a quick question about when you say you fit it to observed cases, is it the beta parameter that you're calibrating to observed incidents?
Well, it wasn't incidence per se, but sort of like prevalence, any cases that we had. So based on the kind of data that we had, it's just the number of confirmed cases that the country had. So we had an Excel sheet for the different confirmed cases for the different days, not sort of like incidence, but sort of like prevalence. Maybe by the time we got the data, some other people had already, healed and things like that. But yeah, that's what we leveraged on to fit the model on.
Okay, and this is for adults and children combined?
Yeah, it was adults and children. Now, that's another thing that we thought we would delay the publication a little bit because we thought we would get much more better refined data that can give us children and adults, so that we sort of like have realistic parameter estimations. But we've tried this, it hasn't been a success. The kind of data that we have had has everyone combined. So the variable for age is missing by much. I think it only has like 5 people for whom age is being presented. So it was hard for us to really tell who was below 15 years, who was, 16 years and above, so that we can sort of like apply the model to the different data sets and then get realistic parameters. So we don't really think we can rely on this, because we did not use like separate data sets for the children and adults to sort of like estimate these parameters based on the data. And that's a limitation. I should have presented limitations. Sorry. Yep.
No, I mean, that's
for this. Yeah.
I think that must be common to any sort of model like this, is you're always limited by what data is actually collected and reported on. So,
Yeah.
but this is incredible and has really, really great applications.